Welcome to the Saving Lives podcast. I'm Eddie Joe. Today, we're going to have a podcast discussing albumin in critically ill patients. For historical context, today is the 8th of April of 2026. Some disclaimers before we get started. All this is evidence-based. There are PubMed IDs as citations for all of these slides, so please read these data for yourself. This is not medical advice. Do not trust me. Also, I do have to plug in my book, the Vasopressor and Inotrope Handbook. It is available on Amazon as well as my Shopify store. Pick up a copy if you haven't already. It helps support my work. So, albumin is extremely controversial in our critically ill patients. People have policies, guidelines, etc., but excuse me, let's see what the data suggests. So first, we're going to go over some background in terms of albumin. We will also discuss the indications of albumin, as well as the indications that we use it for. We will discuss the contraindications, and we will finish this podcast it's going to take about 30 minutes in total, and discuss everything about albumin and Lasix, what we know, what we don't know, and whether the person who speaks definitively about albumin and Lasix is actually correct or incorrect. First question, where does albumin come from? Well, there is an endogenous albumin, and that comes from our liver. Our liver is very smart. It produces between 10 to 12 grams of albumin per day. And out of the total protein synthesis that we do as human beings, it encompasses about 10% of that. We all knew that. This is pretty bland stuff, but the interesting part is, where does the albumin that we provide our patients come from? So we're going to discuss a little bit about the manufacturing process, because at least I find this really cool. So therefore, you have to bear with me because I want to teach it to you. First and foremost, when people go and donate plasma, they take out the albumin from this. So it comes from pooled human plasma. And then they use this process called cold Cohn fractionation. Did I say it correctly? Sure, fractionation. What is this cold Cohn fractionation? Well, it is a process, and I promise you, this is the busiest slide I have in the whole presentation. This is a process where they separate the albumin from all the other proteins that are in the blood that gets donated. And there are several different processes here that are listed that could be used, but the one that is used today is, as I mentioned, that cold Cohn fractionation. And then the actual albumin that's been taken out and underwent that fractionation process, it gets pasteurized. And this is where the cool question comes in. Why does most of our albumin come in bottles? And only as of late have we started seeing it come in plastic containers. Well, it turns out that this pasteurization process comes by ways of taking the actual glass bottles, and they actually heat the bottles, and that's how they do the pasteurization. Back in the day, there wasn't a technology to be able to do this in plastic bottles, plastic bags, and therefore they used to use glass bottles. Thankfully, technology has evolved, and now we could use albumin in these little packages that are plastic, but that plastic is sophisticated technology so that it doesn't dissolve in the process of the pasteurization. So that's something that you learned already in this presentation, had you not known it already, or not known it from before. So what electrolytes are in albumin? Because it's not just the protein on its own, it also has some friends that it goes around with. And the first thing we have to consider is the sodium concentration of albumin. It has 145 plus or minus 15 millimoles per liter of sodium. Therefore, if a patient is already hypernatremic, perhaps you might see an increase in the serum sodium for these patients. The big variation comes in chloride, where the 5% albumin has 128 millimoles per liter of chloride versus the 20% albumin, the hyperoncotic albumin. Now, something really quick. I'm going to use 4 and 5% as the hypooncotic albumin, and then I will use the 25 and 20% as the hyperoncotic albumin for the sake of this conversation. Well, the one that has the higher concentration of albumin, the 20% in this case, has 19 millimoles per liter of chloride in it. Also, I don't have sophisticated editors, so I'm just going to blow through everything and do this all in one take because I have to pick up my daughters. I don't have a lot of time. How much does albumin cost? This is what makes using albumin so tricky, because you want to have a good cost benefit from this particular product. And these numbers that you're seeing up on your screen are not what your hospital sees. It's not what your patients see, but this is a good representation of the average price. And this is considered the average wholesale price. I obtained these numbers from UpToDate. And the date that I obtained them on was on the 11th of January of 2026. But it gives some consideration as to how expensive albumin is and why albumin it's frowned upon to use it in your patients. For the 250 cc vial, it costs between $70 to $107. For the 500 cc bottle, that is $140 to $215 per 500 cc's. If you were to take into consideration how much a bag of saline costs, which is about $1, LR costs about $1.60, let's say, Plasmolite about $1.80. This is a significant difference, a significant increase in cost by giving patients albumin, at least the 5%. And we will talk about what I think about the 5% at the end of this lecture. The 25% albumin, this is the one that comes in the smaller packaging. The 50 cc vial or 50 cc bag is between $56 and $108 versus the 100 cc vial that costs $112 to $216. That's expensive stuff. So if you're going to use it, make sure it counts. Why do our patients develop hypoalbuminemia in the first place? We notice that when we check our daily labs, or every so often labs, their LFTs, etc., that the albumin populates. You see it drift down every single day, but why is this happening? Well, first and foremost, there is capillary leak that's taking place. Capillary leak means that when the patient is having an inflammatory issue where you start destroying the glycocalyx, the tight junctions kind of loosen up, albumin tends to escape into the extravascular space. Then there's also a reprioritization of synthesis. The body, when it's sick, does not want to produce albumin. It needs to produce other mediators, other proteins, and therefore albumin takes a back seat. There's also plasma dilution. We end up giving patients several liters of fluid, typically when they are sick, and therefore the albumin counts in the serum are going to go down because of that. The body is also chewing up the albumin in the process of people who are critically ill. And last but not least, our patients who are critically ill are not eating, they don't have good protein intake, and therefore malnutrition is also contributing to the fact why our patient's serum albumin is decreased. What are the physiologic benefits of giving patients who are critically ill albumin? Well, first, these data from 2019 suggest that there is protection as well as restoration of the endothelial glycocalyx, which is the lining on the inside of the blood vessels, by using albumin. So, benefit there. But there is also a possible improvement of the microcirculation, and these are per data that were published just last year in 2025. Of course, read these data for yourself so you can determine whether you're convinced or not of these things. What are the indications for albumin? Now, these particular indications were obtained from the package insert, not what you do at your shop, not what I do at my shop, but what is actually on the package insert. And the first indication are for patients who are hypovolemic, for fluid resuscitation. This is where we see it in patients who are septic or after cardiopulmonary bypass, things of that nature. It is also indicated in cases of acute nephrosis. These are where patients are actually urinating out all their protein, and therefore you need to fix their albumin levels. ARDS, and here it is provided to spare them from receiving crystalloids, which would third space and worsen the inflammatory process in the patient's lungs. It could also be used, it is also, indicated for ascites for patients after cardiopulmonary bypass. Sometimes it's used as priming, but that's a different conversation. And it is also indicated for hypoalbuminemia from burns. So a couple different reasons why this is being used, and this is all from the package insert. Now let's get into the sexy stuff. Does albumin improve survival in sepsis and severe sepsis. Notice that we're not talking about septic shock. We are talking about sepsis and severe sepsis. And the short answer to that question is no. It does not improve survival. And we're talking about both the 4% albumin as well as the 20% albumin. And this is from the SAFE trial as well as the ALBIOS trial, which were published in 2004 and 2014, respectively. For a little bit of context, the SAFE trial, again, was published in 2004. It was a randomized controlled trial where they gave patients 4% albumin, and they enrolled almost 7,000 patients into the study. Meanwhile, the ALBIOS trial, which was utilizing 20% albumin, registered, or better said, they enrolled over 1,800 patients into the trial. So both the 5% as well as the 20% albumin did not show a benefit with regards to survival. Now, this is my second busiest slide because I actually have to read this. And if you're just listening to this, just know that there is a video version on Spotify as well as Apple Podcasts. What if we do multivariate analysis adjusting for baseline factors, and then they do this analysis 7 years after the first trial took place? It's like, what were you guys waiting on in order to publish this? But when they looked back at the SAFE study and they did this statistical gymnastics, they did find that there was a survival benefit. And their adjusted odds ratio for death was 0.71, which means that could be beneficial for these patients. But if we possibly could have this survival benefit, how much would it cost and how many patients will we have to treat in order to see this benefit? And here I took some liberty. You could criticize me all you want, but I used the values from up to date that I mentioned earlier in this lecture. It would cost about $1,300 or over $1,300 per patient to be able to see a mortality benefit. And that is with the number needed to treat of 19.2. So in other words, you would end up spending $1,300 by 19 patients in order to save one life. How much is a life worth to you? That is worth considering. Obviously, I'm not an administrator. I would do whatever it takes to save a patient's life, but these are just the statistical realities we have to deal with because money is not infinite. Now, does albumin improve survival in septic shock? We found that it does help in severe sepsis and sepsis with the 4% albumin, but they had to do all those statistical jumping jacks. But what about septic shock? The short answer to that is yes. And this was found in the ALBIOS trial, which was that study with 1,800 patients that looked at 20% albumin. Not the 4% albumin, the 20% albumin. And what protocol did they use in order to have these findings? Well, on day one, the day that these patients were enrolled, they received 300 milliliters, 300 cc's of 20% albumin, which is a total of 60 grams of albumin. And then after that, they did maintenance dosing of this 20% albumin to try to keep the albumin level greater than 3. So in order to have these findings, in order to see this mortality benefit, how much money would we have to spend? And again, this is not all about money, but this is just the decision that the administrators are making at your hospital to say, hey, by the way, we're going to take this off, or you need to have special allotments of sorts in order to be able to order this. So in order to see this mortality benefit, you would have to spend about $1,100 per patient with a number needed to treat of 15.9. So just keep that in mind when you see a kind of higher number needed to treat. We wish this was a smaller number, to be honest. Now, does albumin help achieve hemodynamic stability faster than providing patients with crystalloids? And the answer to that is yes-ish. And here's why, because it's not as clear-cut and black and white or as easy to analyze. And again, since all of this is not easy to analyze, I recommend that you read these data for yourself because you might disagree with me, and that's okay. So the ALBIOS trial found that giving patients 20% albumin, these patients had a faster achievement of their blood pressure targets. So they weren't hypotensive as long as before. In addition, there are numerous studies that demonstrate that there is a reduced duration of vasopressor support when patients receive the 20% albumin. Again, the ALBIOS trial is one of those, but there are other trials listed underneath on the bottom of this slide. But that poses the next question. If we're going to give our patients albumin to see these potential benefits, when should we provide them with albumin? Like, should we give it to them earlier, or should we wait a little while? And that's this question. Should we use albumin in the early resuscitation of sepsis? And the short answer to that question is no. We should wait a little while. Here's why. First, the Surviving Sepsis campaign states that we should only provide albumin after large amounts of crystalloids. Thanks, Surviving Sepsis campaign, for that recommendation. But what is considered to be a large amount of crystalloids? Digging further into that question, it's about 3 to 4 liters of crystalloids. So just something to take into account. Now, this retrospective data that was published in 2021 states that we should wait 6 hours before we provide albumin to our septic shock patients. Because any albumin that was provided before these 6 hours, again, this is retrospective data, so do with it what you choose, there was found to be no physiologic advantage to giving albumin earlier. So give them 3 to 4 liters. If at 6 hours they're still not responding, the way that you want to define responding, which that's a different conversation within itself, then you can consider giving these patients albumin. Overall, there is a lack of survival benefit. It's something that was recently found in a 2024 feasibility study where they randomized 301 patients. And there's also these newer data, again, from 2025. This is a retrospective study of almost 10,000 patients where they found that 20% albumin could cause renal impairment. So, we have some trickles over here that we're seeing some benefits, but some trickles over here that we're seeing some adverse effects. It kind of leaves you hoping that there'd be some newer, more robust data, but the question is, who's going to fund a study that's going to cost this much money using albumin? It's just not going to happen. One of the big arguments for using albumin is that there is a concern, or better yet, a belief that you're going to be able to spare using other fluids such as crystalloids for resuscitation. So how much volume sparing could we find with 5% albumin? And if you just use the hypothetical numbers, let's say you give somebody 5% albumin, 1 liter of it, you could expect to save 3 liters of crystalloid. Another piece of data states that for every 1 liter of albumin, of 5% albumin that a patient gets, you're going to save 5 liters of crystalloid, which would seem like a pretty good trade-off to avoid drowning your patients, for lack of a better term. However, there's a reality to this. And the reality is that for every 1 liter of albumin, you only spare 1.4 liters of crystalloids, which is not as powerful as we all hoped and we planned. And this is suggested by 3 different papers, which you can read for yourself if you want to dig into this a little bit further. Now, 25% albumin, this is where you get your bang for your buck. For every milliliter of 25% albumin, you will see a 200 to 400% increase of the intravascular space. So you will see that increase in the intravascular volume by giving patients the 25% albumin. So that's a better thing than just that 1.4 that you would find with the 5% albumin. Switching gears now. Let's talk about albumin after cardiac surgery. Should we use albumin to resuscitate patients after cardiac surgery? This is something that's dear to my heart because I help run a cardiac surgery program. I am the intensivist who takes care of hundreds of patients after cardiac surgery every single year, and we have good outcomes. But we do use albumin. But should we? There are 4 trials that have been published within the last 10 years, let's say. It's been published since 2019 all the way to 2025. 4 different trials: the ALBICS trial, the ALBICS-AKI trial, the HAS-FLAIR trial, and the HAS-FLAIR II trial. These 4 trials all looked at using albumin of different concentrations in cardiac surgery patients. So first, Let's talk about the ALBICS trial published in 2022. This was a randomized controlled trial involving almost 1,400 patients, and they used albumin, 4% albumin, just to clarify. They used it for both priming as well as resuscitation after cardiac surgery. And they randomized these patients to get either 4% albumin or Ringer's acetate. It's like a cousin of Ringer's lactate, but they use acetate instead of lactate. I'm not going to discuss all the nuances of that, but just know it was Ringer's acetate. And what they found is that there was no difference in outcomes whether they used the 4% albumin or the Ringer's acetate. They did note, however, that patients who received the 4% albumin did have an increased risk of bleeding. So complications were found with the 4% albumin. Then they went ahead and looked at patients who were at high risk for AKI, and they performed the ALBICS-AKI trial. This randomized controlled trial published in 2025, in other words, very recent, looked at 611 patients after cardiac surgery. And they gave these patients 300 cc's of 20% albumin, not the 4% that was done in the other ALBICS trial, but 20% albumin. And they found that here, this 20% albumin actually caused harm in these patients. There was an increase in the incidence of acute kidney injury. So where does this put us? Well, one of the things we have to think about is that they gave the methodology that they used to determine who they could enroll into the patients is something that I recommend that you look up for your cardiac ICU, because there's variables in how you might practice at your institution to how they conducted this study. But moving on, the HAS-FLAIR trial published in 2019 was a pilot trial. They enrolled only 100 patients, and they gave patients after cardiac surgery 200 cc's of 20% albumin. Here, the patients received less fluids altogether when they received the albumin. They had less time on vasopressors and less vasopressors altogether. So these are all good things to show possible benefit by using 20% albumin. So then they went ahead and made a part 2 of this study, the HAS-FLAIR II trial, that was published in 2024. This was a randomized control trial, no longer just a pilot study, and they enrolled a total of 480 patients. Here they gave the patients 400 cc's of 20% albumin. And they found that these patients required less fluids, but there was no difference in vasopressors or in time on vasopressors. Now, they did a secondary analysis on this patient population, and they were looking at cardiac surgery associated AKI effects. That's a mouthful. And this was 104 patients for the secondary analysis, and this was published in 2025. Here they found that there was no difference in AKI incidence. However, if the patients had AKI stage 2 or stage 3, there was a decrease in the severity of their AKI and the duration of their AKI. And there was also more renal recovery by using 20% albumin. So we have the ALBICS-AKI trial, which shows that there is harm, and then we have this particular study, which shows a benefit. So what do we do with this? Well, kind of looking at these as individual trials, we need to look at who were the patients enrolled into the different trials, because this will allow us to better stratify who would benefit from the 20 or 25% albumin and who will not. So in the ALBICS-AKI trial, they actually found that the albumin hurt the kidneys, and in the HAS-FLAIR II trial, they found that the albumin helps the kidneys. So what do we end up doing? Because it's obviously not clear cut. One of the things that we all like to do, because we like to make the numbers pretty, is giving patients potassium, for example, because their potassium is low, magnesium, phosphorus, etc. But should we provide our patients with albumin just because their albumin level is low? Well, turns out in sepsis, there's no data to support that we should do this. In decompensated cirrhosis, there's also no data suggesting that we should do this. So yeah, don't use albumin just to make the numbers pretty. Another patient population that we need to be careful with is the patients with traumatic brain injury, because this is where albumin is actually contraindicated. This was a subgroup analysis from the SAFE trial that found that 4% albumin is harmful to patients with traumatic brain injury. Did they look at the 20 or 25% albumin? No, this study did not look at that. So that is something that's being discussed in the background as to whether that patient population could tolerate this. Now, to finish up the lecture, let's talk about albumin and Lasix, because this is a super controversial topic. Now, these two are friends just without us discussing them, because albumin actually transports Lasix to the kidneys, and therefore they need each other in order to work. So you would say, if the patient was hypoalbuminemic, perhaps the Lasix isn't going to work as well. Let's put that to the test. What are the effects that we expect to see with the combination? And this is the result of a systematic review and meta-analysis looking at 422 patients with 13 different trials. I know this is not impressive. 422 patients, that's all we have to base our knowledge of albumin and Lasix, but that is what we have, and these data were published in 2021. Giving patients albumin with Lasix showed an increase in urine output by almost 32 milliliters per hour. Okay, cool, thanks. But this effect was only seen for a 12-hour duration. After that, kind of loses its gas, so to speak. And these patients, in order to see this particular benefit, would have to receive over 30 grams of albumin, so more than 2 doses of albumin, not just one little vial necessarily. One of the things that has been teased out is that in order for this to work, you need to give the albumin first and then the Lasix, not the other way around. Now, if you do want to give your patients albumin and Lasix, how much is this going to cost? And of course, we're going over hypothetical numbers here because, every institution has different pricing strategies. So if you want to do the 25% albumin, every 12 hours, it's going to be about $300 a day versus the 25% albumin every 8 hours, that's $450 a day. If you are considering giving patients the Albumin Lasix combo, you might as well make it have the best bang for your buck. So who are the best candidates for albumin and Lasix? And these are the patients who have a low serum albumin level, less than 2.5 grams per deciliter. This is where you're going to have your bang for the buck. In addition to that, your patients who have an impaired renal function, in other words, a creatinine greater than 1.2 or a eGFR less than 60. These are the patients who could benefit from this the most. Now, is there a mortality benefit in giving patients albumin who are septic with hypoalbuminemia? And this is retrospective data, over 3,300 patients, but the answer to that is yes. The concoction that they used to determine this mortality benefit in giving this albumin Lasix combination was one arm received albumin for 18 hours versus another arm received albumin and Lasix for 25 hours. So here they saw the mortality benefit, where the in-hospital mortality for the group that received just the albumin was 38.7% versus the albumin and Lasix group saw a 25.1% mortality, with a number needed to treat, which is under 10, which is good enough for me, of 7.4. Now, the important thing to take into account here is that this is retrospective data. Even though they have a whole bunch of patients, over 3,300, it's still retrospective data. So let's wrap this up, and because we're already kissing 29 minutes per my timer, and this is way too long for me to be rambling, especially when I need to go pick up my daughters. The main limitation for using albumin is the cost. The bang for the buck is simply not there. I mean, I still use it from time to time in my practice because that's just the way I practice, but a lot of institutions don't let you use it. The big key factor I took away from doing all this research is that there's no compelling data to use the 4 or 5% albumin. I mean, I don't know if I'm going to keep on ever using it in my practice. It's just not, the data's just not there to suggest that there's something good or something positive or even a trend. It's just not there. Now, 25% albumin is where the bang for the buck is, if you want to make that argument, where you could see an improvement in septic shock survival. You could also see different studies like the HAS-FLAIR II trial, where it attenuates severe acute kidney injury in the cardiac surgery population. And it could also help with diuretic resistance. So couple different places where the 25% albumin could help. All in all, that's my quick little lecture. Quick, 30 minutes is not quick. But that's my lecture on albumin in critically ill patients. Don't forget to check out my book, the Vasopressor and Inotrope Handbook. I need to go pick up my daughters. Hope you guys have a great day. Bye.